So next is obstructive sleep apnea. You see a morbidly obese 60-year-old gentleman whom you think may benefit from a total knee replacement. He claims he has gained weight in the last few months and cannot exercise because of the excruciating pain in the left knee. He also complains of increasing lethargy, and you notice him dozing off during the consultation. His wife claims he has not been sleeping well and his snoring has gotten much worse over the last few months. Based on this, you suspect he has obstructive sleep apnea. What is obstructive sleep apnea? Obstructive sleep apnea is characterized by repeated episodes of partial or complete closure of the pharynx or pharyngeal muscles, leading towards the closure of the respiratory airways, upper airways closure, that causes reduction or total cessation of airflow during sleep, and that results in hypoxia and hypercapnia, and that disturbs the sleep cycle with awakening. What impact it can have on the other systems? So repeated changes in the arousal levels, hypoxia and carbon dioxide retention leads to surge in the catecholamine levels. And catecholamines coupled with stress response and absolute changes in the intrathoracic pressure, this predisposes the patient to being at risk of myocardial ischemia, arrhythmias, left ventricular hypertrophy, pulmonary hypertension, cerebrovascular accidents, hypertension, atherosclerosis, and diabetes. How common is obstructive sleep apnea? Up to 5% of the UK population have obstructive sleep apnea. 80% are undiagnosed. Up to 40% patients presenting with surgery have at risk of obstructive sleep apnea. It is associated with population with obesity, hypertension, diabetes, coronary artery disease, stroke, and atrial fibrillation. How is it diagnosed and classified? Obstructive sleep apnea is diagnosed by doing the sleep studies called polysomnography. It is classified by grades depending on the number of apneas or hypopneas recorded during the study per hour of sleep. It's called apnea hypopnea index. So severity none. If it's apnea hypopnea index AHI is less than 5, it's none. More than 5 but less than 15 per hour, it's mild. More than 15 to 30, it's called moderate, and more than 30 is called per hour. As you are concerned the patient may have obstructive sleep apnea, you call the ENT sleep clinic to arrange for polysomnography. The next available appointment is 18 weeks away, but the patient is unwilling to wait that long. What else can you do to aid in the diagnosis of obstructive sleep apnea? There is a mnemonic called stop bang assessment. So stop bang assessment: S, evidence of snoring; T for tiredness; O for observed breathing, choking, gasping; P, blood pressure. So stop and bang. B for body mass index; A for age; N for neck circumference; and G for gender. So this is stop bang, and if someone has stop bang score more than 3, that risk of moderate to severe obstructive sleep apnea, and high sensitivity is more than 80%, low specificity 30 to 40%. The patient reassures you that he has been snoring for years and is keen to have the procedure. However, he wants to know what perioperative complications are associated with obstructive sleep apnea. Anesthetics are concerned because it will be difficult intubation and difficult mask ventilation, and surgical concern higher rates of post-operative critical care admission, unplanned reintubations, cardiovascular complications, post-operative arrhythmias and myocardial infarctions, respiratory depression associated with opioids, intravenous, intrathecal, and epidural. He is still keen to have a procedure. What can you do to minimize his risk of developing post-operative complications? So multidisciplinary discussion between anesthetist and intensivist, admission to HDU after surgery, provision of nocturnal CPAP. There is evidence that nocturnal CPAP can reduce the chances of perioperative complication, incidence of hypoxemia, cardiac ischemia, and unplanned critical care admission. Thank you.